let me make sure that I am sharing my screen, but we're going to start up our Thursday research review. There we go. All right, let's move these two studies together. And we're going to start from right to left. We got 4 studies on the docket. This is actually going to be relatively quick. The first time I did this with new tech, I got this done in about 10 minutes. So let's see if I can match that. So, association between metabolic syndrome and risk of incidence of low back pain, a retrospective cohort study using real-world data from Japan. There's a few highlights, and the study kind of speaks of itself. Metabolic syndrome was associated with an increased incidence of low back pain. If you had abdominal obesity and some of the additional metabolic markers, you had further increased risk of low back pain. And how do they really find this out? Well, they took health insurance claims data and health checkup data from government employees across all prefectures except Tokyo in Japan, and they wanted to take a look at low back pain incidence. So really, during their screening, they first made sure that participants that they tracked who went through this had no low back pain in the prior year. So this would be new incidents from the time they were studying. And what they found was exactly what was in the highlights. Among 111,100 participants over about that 3-year period, almost 17,000 developed low back pain, 15%. That's not a little. That's quite a lot. And it's just as the highlight said, when they put it through their analyses, in addition to abdominal obesity being an elevated risk factor. So just metabolic syndrome alone, which essentially is things that affect your metabolism. It's metabolic syndrome. So we've got different blood markers. We've got different physical markers like that midline obesity. We've got prediabetes. We essentially have all of these things wrapped into, you're getting into a state of, it's not disease, but you're not as healthy as we frankly want you to be for where you're at in life. So this metabolic syndrome really kicks up. So, hey, I'm pre-diabetic. Maybe not fully yet, but you know what? You're on your way. You know, I've got a little extra in the tummy. Well, okay. You maybe not have full-on morbid obesity, but we shouldn't be carrying around that much. And now we have data to really show that when we add these things together, it's increasing our risk for developing low back pain. And now, since this is really centered around metabolic syndrome, not all incidences of low back pain have a mechanical dominating source, which is really highlighted by this study. This is metabolic, chemical, physiological mechanisms, things that will increase the chances of you developing low back pain. So it's not that I can therefore, just brace my core and do all of these physical things to make sure that I'm reducing my incidence of low back pain. I also have to take care of what I'm putting into my body, nutrition. I have to make sure I'm getting adequate sleep, because there are other things that play into developing low back pain. So just in summary, metabolic syndrome, they tracked them. Did these people then develop low back pain? A good chunk of them did. So not all of your causes of low back pain are going to be from an obvious mechanical, I slipped and fell. I took a shovel and I tried to lift 200 pounds of snow and twisted funny. No, some of it is, I just haven't really been taking care of myself as I want to be, typically. And I am now putting myself at risk for developing low back pain. And it's not going to be because of a mechanical issue. This is going to be because of a metabolic and chemical issue. So no matter if you are a desk warrior or if you are a factory worker, not everything is going to be mechanical. And that can be the bugger. Like, the people that are office workers all day, but I didn't do anything to cause low back pain. Right? Because you're going right to a mechanical thought. Maybe it's not mechanical. Same thing with factory workers or blue collar workers. They may blame the mechanical work, which certainly is a component, but they aren't considering that maybe it's them not taking care of themselves that is keeping them in recurring episodes of low back pain. So just some food for thought. Let's go into the next one. Running improves mental health symptoms and pain catastrophizing in adults with chronic low back pain. This one is just straightforward. So even if it didn't actually measure, did it improve low back pain overall, part of the actual healing process is considering the mental strain that that having chronic low back pain will take a toll on somebody. And it is something that we have to have frank conversations around. Because if you have chronic low back pain, let's think of it this way. A lot of the patients that I see who have these chronic issues, when we finally get them out or on their way out, they literally change in front of me in the office. Like if you ask them and show them videos of who they were before, so when they had the actual chronic low back pain incident, they were comparatively more just dour, gloom, angry, whatever you want to picture. They were typically more anxious. They didn't want to do things because it could, set off the low back pain. All of these factors came into play. And even if this study showing running didn't necessarily improve the back pain, they did find was that it basically improved every mental health marker they measured except anxiety. So what was the actual study? 40 adults right around the age of 33, give or take, were either put on a wait list or they were told to have a 12-week running course where they progressively increased from they did a progressive run walk interval training. Then they measured the outcomes via questionnaires. So at 12 weeks, running improved overall mental health symptoms that were noted. So they improved depression symptoms, stress symptoms, pain catastrophizing. So people would want to actually do more things because, look, maybe you didn't want to run because you're like, all right, it might, increase my back pain a bit. You got through it. It's like, well, maybe I did have a little flare up, but man, that wasn't nearly as bad as I thought it would be. Well, look, your pain catastrophizing is down. You're now more willing to do more stuff, and you're just going to then keep going in your recovery journey. All right. And then, like I said, not anxiety symptoms. So something as, attainable, doable as running, if that can improve this, that is fantastic. So, for those people that don't maybe want to hit the gym, great. I can now say, go walk and run. For the people that do want to hit the gym, hey, look, as long as we bear the load down to a tolerable level, we can probably get similar results as this. Basically, when you have low back pain, you have to keep moving. So as long as you have a provider who checked off all of the red flags, like, you're good, you don't have anything scary we need to worry about, which again is a minutia, but one we still have to check for. And you can have somebody in your back corner helping you through and just cueing you like, yep, run, do it. We have the study, 12 weeks run. It'll help the mental health side, if nothing else, which is a big factor overcoming a lot of these chronic issues. Then you can have somebody just grading up your recovery, your rehab, your training, and just giving you different levels of exposure. And then you're going to have great results. I know you will. Now, the next two deal around subacromial impingement syndrome, which I'm going to do syndrome in air quotes. There's a lot of real estate and things going on in this area of your shoulder. So it's no surprise that issues abound in that area, but essentially the nuance comes into the whole impingement. It's not actually impinging or pinching tissue in there. It's just that sometimes things get angry. Things then just argue about who needs how much space where, so that they're not pinching together, but you put a couple of rowdy people in a confined space, they're going to let people know they're there, and hence you have this impingement syndrome in this specific area. So two things on the docket. First one is a little bit of a restricted study, but we can at least see what it said rather than going through all the methodology of it. So did the addition of thoracic spine, so mid-back, spinal manipulation or mobilization with exercise in adults improve subacromial impingement syndrome or symptoms thereof? Short answer, yes. So here's the thing. They searched a bunch of literature and they really found 3 studies that stood out and met their criteria for the question they asked. And that question, again, reminder, does adding thoracic spine manipulation or mobilization to exercise in adults with subacromial impingement syndrome improve shoulder range of motion, pain, and or disability? Here's what the studies actually said. 2 of the studies reported that the combo of thoracic spine mobilization and manipulation and exercises resulted in more significant improvements in shoulder range of motion, pain, and disability compared to exercises alone. 1 study also then compared it to ultrasound and found that the combo of thoracic spine and shoulder mobilization to exercises was superior to ultrasound or exercises alone. Really, I like this study not because it highlights something that I do per se, but it highlights something that has a great safety profile and access profile that you can incorporate if you have this, and then not have to get something further up the chain. So now you don't have to schedule or always schedule a potential doctor's visit to then get a prescription of a cortisone injection or other injection that frankly may or may not be warranted at that time. And now we're dealing with the cortisone injection, which there are own issues there as far as joint health is concerned. There's the medical bill associated with it. There's the whole, if it does work, if it doesn't work. The patients that I've seen, there's very, very few people that get just a singular cortisone injection and things are good. Typically, they turn into quarterly or even biannual injections. And now we're just adding things up and really pushing things down the road for not addressing the issue at hand. And if this is something that a lot of people have access to with a fantastic safety profile, because thoracic spinal manipulation and manipulation in general is incredibly safe, especially when you compare it to other options that patients get out there. And again, while not required, I think that's something that should be highlighted. Even though it, adding it was superior, that doesn't mean that the exercises alone didn't help. But if it's something that is very, very safe, very, very accessible, and then may reduce my likelihood that I'm going to bog down the medical hospitals with my shoulder complaint that maybe doesn't need that actual injection after all the better. So again, I like this because it highlights something I do. It's great because it's something that highlights a very attainable, a very manageable, safe potential intervention that you can add on to help you get through whatever's going on in your shoulder to keep you as active as possible. So I like that there. We're going to end on a similar study looking at subacromial pain syndrome, but looking at the neck now. So instead of looking at an intervention, so if I do this, does something happen? Now they looked at, if somebody has this, do we see other things with it? And in this study, they did cervical range of motion in individuals with and without chronic subacromial pain syndrome. Highlights again, do a very good job of basically summarizing the study in and of itself. They found that reduced cervical range of motion has been observed in those with that subacromial pain syndrome. Individuals had a higher likelihood, so quite a bit, 1.5 to 4.25 times higher prevalence of cervical range of motion issues if you had subacromial pain syndrome. And things that contributed to those deficits, so the cervical range of motion, were things such as the duration of shoulder pain, if they had neck pain concurrently with it, and age. So really, this is the entire point of what I'm going to say at the end is, don't be so myopic and look, hey, I have pain here. All right, I'm only going to look here. No. I could get into an absolute rant about different studies like extremity pain of spinal origin. So especially the proximal joints, such as the shoulder and hips, have a ton of overlap of spinal factors to them insofar as expressing pain and issues. But another time, another place. For now, this should be one of those things where, from a patient standpoint, so if you're listening to this in a patient, hey, make sure that you are finding a provider that's looking at least a bigger picture, even if it's not necessarily the whole picture. And if you have shoulder issues, they're at least also addressing and looking at the neck, and potentially other things such as the elbow and wrist, okay? Because these things are so close in proximity. A lot of muscles overlap insofar as actions that they do. So for example, do I want to tilt my head to my right shoulder, or do I want to bring my right shoulder to my neck? Like, when you ask a patient to do that, they're going to do both at the same time. They are extraordinarily interlinked. And from a clinic or from a patient standpoint, find somebody who's going to look at both, because sometimes if you don't address both, the singular problem may not actually get as good or better as fast as we wanted, or it won't entirely resolve the way we want it to. From a clinician standpoint, if you're on the other end as a clinician, then please, 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 please consider this. If you have patients with shoulder issues, look at their neck. We can also take it vice versa. It may not be one of those you have to automatically do an exam, but if I have a patient complaining of neck complaints, I may just ask, like, hey, are there any issues with your shoulders, any inability to reach overhead or do these other tasks, just dexterity movements? Because they won't even think about it. It's like, nah, doc, I have pain right here, and it's when I move my neck. It's like, okay, great, I'll address it. You're probably right. Most of the issues probably there, but let's just check. Any issues like, oh yeah, when I reach up here, all right, now we're starting to get somewhere. I notice pain in my neck still. Oh, okay, why? Then we can just go from there. Again, it's not to say you're always going to have both problems at the same time, but they are very, very intimately linked. And there's a good chance that there's at least some compensatory issue or thing, item that can be addressed. Whether it will directly or indirectly help care, that's up to the individual at the time. So your patient, the condition, etc. But essentially, we come down to it's a betting game. Individuals with subacromial pain have a much, much, much higher prevalence of developing the cervical range of motion deficits. We could say it's direct compensatory mechanisms. I'm going to avoid doing certain things that irritate my shoulder. So I'm going to move my back and subsequently neck to accommodate. So now my shoulder's not really moving as much, but the rest of me is. We could just get into a long discussion about that, but I'd rather not. We have 4 studies. We kept it relatively short. I've said my piece. I've ranted enough. The highlights do most of my job for me. So thank you for sticking with my rant for as long as you have. Until next week, appreciate you. And again, if you have any suggestions or comments, please feel free just to leave them in the video. Thanks.